Okay, so this section is angiology or the vascular system. Question number one, a medical student is studying the regulation of blood pressure by the human nervous system, endocrine system, and certain pharmacological agents. A diagram that shows the major factors that determine blood pressure is shown. This picture. Which of the following labeled factor is affected the most by the adrenergic antagonist, alpha 1 adrenergic antagonist? And then they give you the diagram. In diagram, you have A, B, C, D, E, F. Okay, so SV is stroke volume, heart rate, peripheral vascular resistance. I mean, the names are given to you down there. Okay, so let's see how we can do this question. The most important thing here is in this question is which labeled factor is affected the most by alpha 1 adrenergic receptor amongst the choices that are given. Okay, so to understand this, let's talk about blood pressure. How is blood pressure regulated? Well, blood pressure, the question itself tells us it's regulated by the endocrine system and by the nervous system. Obviously, the nervous system is faster than more than the endocrine system. So whenever there is blood pressure goes down and you want to elevate your blood pressure, then the nervous system comes first to sort of stabilize the blood pressure temporarily until the endocrine system, which takes longer to act, can maintain it. So nervous systems simply balances it temporarily, and then for long-term regulation is the endocrine system. Let's talk about the nervous system. How does the nervous system regulate blood pressure? In brainstem, in the brainstem, there are adrenergic neurons. Adrenergic neurons are those neurons, and I'm drawing it for you. So this vesicle comes in and it degranulates from the adrenergic neuron and it will release norepinephrine. Okay, so this is adrenergic neuron. Where? In the brainstem. So let's just say brainstem. So in brainstem, you have adrenergic neuron. These guys will, in response to low blood pressure, will release norepinephrine. And norepinephrine then will go act on its receptors. What are the receptors of norepinephrine or adrenergic receptor? It's alpha 1, okay, beta 1. Let's make some room. Alpha 1, beta 1, and beta 2. And of course, alpha 2, which is the presynaptic. It's found in the presynaptic neuron, okay? So norepinephrine, let's say first, we have alpha 1 first. Let's say norepinephrine stimulates. It stimulates, I'll put a plus sign, alpha 1 receptor. Alpha 1 receptor is primarily found on blood vessels. Okay, so it's found on blood vessels. And if it's found on blood vessel, what does it do? It causes vasoconstriction. I like to draw, so just give me a second because it helps students to learn much better. That's why I draw. Okay, there you go. So alpha 1, as we said, is going to cause vasoconstriction. Vasoconstriction. That's the job of alpha 1. I think I'm going to run out of the room. Let me write it here. Vasoconstriction. So that's the job of alpha 1. And if you constrict and squeeze blood vessels, obviously blood pressure will increase. Okay? If you squeeze blood vessels, blood pressure will increase. So this vasoconstriction leads to increase in blood pressure. Maybe before I go to beta 1, let's talk about how do we even know what is blood pressure? Blood pressure is depending on two things. So I'm writing it here. Blood pressure depends on two things. Imagine there's a tube, in this case blood vessels, and in the tube there will be blood volume. So how could the pressure on the wall of the artery? So blood pressure should be defined as the pressure or the force produced by fluid against the wall of an artery. So if there is more volume within blood vessels, this will increase blood pressure. So that's one way. Also, if there is tone of blood vessels or peripheral vascular resistance, let's say, The next thing will be increasing tone. Okay, so tone. Now, if you were to write this down, the tone is, we can say vasoconstriction, vasodilation, right? Vasoconstriction will cause increase in tone, vasodilation will cause decrease in tone. So peripheral vascular resistance is the term that should be used for tone. For volume would be, that's produced by the heart, is cardiac output. Okay, so blood pressure is directly related to increasing cardiac output and increase in peripheral vascular resistance. If you increase cardiac output, blood pressure will increase. If you increase peripheral vascular resistance, blood pressure will increase. If you decrease cardiac output, blood pressure decreases. If you decrease peripheral vascular resistance, blood pressure decreases. So this is the formula that you should know and understand it. Blood pressure. Cardiac output is the function of the heart. Okay. And peripheral vascular resistance is the function of vessels. And this specifically arterioles. Arterioles. Okay. So memorize that. Arterioles. Not venules, not arteries, not capillaries. Okay. All right, coming back to our previous diagram. So adrenergic neuron in the brainstem release norepinephrine. Norepinephrine acts on alpha-1. Alpha-1 is generally, alpha-1 generally causes smooth muscle contraction. Depends where it's found. So I'm not going to talk about it's found in the iris, it's found in multiple places like the urinary bladder. That's not our concern. I'm only going to talk about where are these receptors found and that are important in terms of blood pressure. So alpha-1 is found in blood vessels, and if you stimulate alpha-1, it will cause vasoconstriction. It will squeeze these arteries. It will cause vasoconstriction. Okay, and vasoconstriction increases blood pressure. Next thing is beta-1. Beta-1 is found on the heart. Okay, it's found on the heart. So if so, then what is the function of beta-1? It's found in the heart, and it's also found in the kidneys. It's found in the heart and kidneys. Okay, so increases heart rate. That's number one. So stimulating of beta-1. So norepinephrine will activate beta-1. Activation of beta-1 leads to increase in heart rate. It also increases heart contraction. HR is heart rate, HC is heart contraction for abbreviation purposes. Okay, all right. So that's what be the function of beta-1. Beta-1 is also found on the kidney. Okay, also found on the kidney. And stimulation of beta-1 in the kidney will increase renin secretion. It releases increase in renin. And renin in terms increases angiotensin 2. Okay, and subsequently will increase aldosterone. Okay, so that's the purpose of renin, increasing angiotensin 2 and aldosterone. Okay. So there's good. That's your kidney. I did it dark, but it's okay. Okay, so beta-1 is found in the heart, and beta-1 is also found in the kidney. In the heart, stimulation activation of beta-1 by norepinephrine will increase heart rate and heart contraction, and stimulation of beta-1 in the kidneys will increase renin production, and renin will lead to increase in angiotensin 2 and aldosterone, and then we'll talk about it further. Okay, beta-2. Beta-2 is found on blood vessels. It's found in blood vessels. Remember, it's found in other organs too, but I'm only talking about blood pressure. So we're going to focus on blood pressure and not anything else. So beta-2 is found on your blood vessels. I like drawing, so for those of you, just be patient with me because it helps you learn more. Okay. So beta-2, activation of beta-2 leads to vasodilation because it's smooth muscle relaxant, vasodilation. But beta-2 is primarily found on coronary arteries. Coronary arteries and muscular arteries, skeletal muscle. So if you cause vasodilation in the coronary artery and skeletal muscle, it doesn't affect blood pressure that much. Okay, coronary artery will increase blood flow to the heart, and you would need that. In skeletal muscle, you need that. That's like the flight or fight mechanism. From that perspective, you may understand. So beta 2 is not found in the heart, and I'm not going to discuss it here. So I'll just put a cross on it, okay? It was just for you. Okay. The next thing is norepinephrine can act and activate alpha 2. Alpha 2, let me change color to blue. Alpha 2, if you activate alpha 2 causes degranulation. It blocks the degranulation. Okay, so it decreases norepinephrine. So it's a negative feedback mechanism. Alpha 2 decreases the norepinephrine activity or release or secretion from the neuron. So it just self-regulates itself. So norepinephrine, if there's too much norepinephrine released, obviously most of it will bind, that you have more available to bind to alpha 2, and that will cause to, and that will lead to a decreased production of norepinephrine. Okay, all right. So this was the mechanism. Now, so the nervous system part is vasoconstriction by alpha 1, increased cardiac contractility and increased heart rate by beta 1, and vasoconstriction by alpha 1, and renin secretion by beta 1. Okay, angiotensin 2 is vasoconstrictor, so it causes vasoconstriction. In addition to that, it activates aldosterone, and aldosterone increases sodium chloride retention. So increases sodium chloride retention, but it promotes potassium secretion. So as a result, potassium in blood will decrease. What is the end result of that? The end result of that is increased volume, because when sodium goes in, water will follow it. Okay, so those are the two things. If you look at it, look, the aldosterone system takes care of the volume, as we see here, blood pressure depends on volume, and angiotensin 2 takes care of the vascular tone or vasoconstriction. Coming back to our question now. Our question is saying, is alpha 1 adrenergic antagonist? Alpha 1 blocker acts on which of these structures that in the diagram? We said alpha 1 acts on the blood vessels. Okay, blood vessels, in this case, vasoconstriction. So if you look at A is stroke volume. Stroke volume is the volume that is pushed or pumped by the heart per beat. So that will be beta 1. And I'll write there to see which receptor, okay? So A is the same as beta 1. Okay, B is heart rate. That is also beta 1. We already discussed it over there. C is peripheral vascular resistance. It's tone of blood vessels, especially arterioles. That's alpha 1. So our answer most likely is C. Okay, so alpha 1. D, contractility, is also beta 1. Volume. Now, volume is, in a sense, that is not because of vascular tone, just pure volume. Pure volume is only increased if you drink water too much, or it's decreased by bleeding or diuretics. In this case, I'll put diuretics. Okay, diuretics. So just for you to, volume is affected by diuretics, by bleeding or hemorrhage, dehydration, diarrhea, vomiting, or, look, so I can simply change this question to one of these options. Or let's say IV infusion, IV fluid, IVF, I'll put. Okay, so if you give somebody IV fluid, it will raise their blood pressure. It can also be affected by, let's say, toxins, maybe endotoxin, right? Endotoxins, which is produced by gram-negative bacteria, such as LPS. LPS, it's high yield for step 1. So all these things will affect E, or blood volume. Blood tone, peripheral vascular tone. Remember, this vascular tone that we see here is primarily due to arterioles. This one, venular tone, is not affected so much by alpha 1. In a sense, it's more affected by nitric oxide. I'll say nitrate. So there's not so much alpha 1 receptor found on venules, and plus this, the smooth muscle layer of veins is much thinner than arteries. Okay, so it doesn't have that much effect on it. Okay, so at the end of the day, our answer was Our answer is C. So C is the answer. Okay, so hopefully this was helpful. Now remember, um, the amount of information I give is very basic, extremely high yield. So I can change this question to aldosterone. I can change it to angiotensin 2. I can change it to alpha 1, beta alpha 2. Beta 2 is not involved, so don't ignore that. Okay? So I give you the basics. That means I can change this question. That's what the USMLE does. I'll simply change to one of these options and changes the whole scenario and your answer. Let's move on to the next question. Okay, so question number 2. A 30-year-old woman comes to the physician for a regular health maintenance examination. She takes no medication. Her last menstrual period was 2 weeks ago. Her blood pressure today is 170 over 100, so that's high. Physical examination. On physical examination and right lateral abdominal brew is heard. CT angiography or angiogram of the right renal artery is shown. The picture here. Treatment with angiotensin to converting enzyme inhibitor will most likely have which of the following acute effect on this patient's renal function? Okay, so I mean, this is questions clear. So this is renal artery stenosis. Uh, there's hypertension, and then especially if you look at the renal artery, they show in this angiogram, look at it, beaded, twisted, like narrowing dilation. That is usually renal artery stenosis. So if you have a young female, okay, the renal artery stenosis, the cause of it is different compared to an elderly person. So I'll tell you that. So number one, look at for the picture. The picture tells you and it helps you, and then the blood pressure. So those are the two things right now that's helping you. But let's say if I were to look for renal artery stenosis, what am I looking for? So in renal artery stenosis, the typical symptoms I'll be looking for is hypertension. That's one. And I'll be looking for headache. Oh man, I'm getting ahead of myself. So headache, two. And I'll be looking for abdominal bruit. I think that was in the question already, so I should have highlighted. Let me highlight it for you. Abdominal bruit. I remember reading it. There you go. Yeah. So abdominal bruit, I'll be looking for that. So when I have this triad, to me, I'm suspicious of renal artery stenosis. So this triad of symptoms always take into consideration. So whenever you have that, the next thing is you should order an ultrasound or angiography. Ultrasound is easier, cheaper, but if you want to order an angiography, that's fine, which will confirm the diagnosis. For step 2 purposes, this is step 1 though. So for step 2 purposes, we'll talk about the test. But in this case, we're giving angiogram, which confirms. That's it. It confirms a renal artery stenosis 100%. And I highlighted that for you in green color. Okay, so we know this is renal artery stenosis, and the question is asking what is the effect of ACE inhibitor on this patient's kidney. Okay, this person already has renal artery stenosis, and that's what we're going to look into. Now, because there's two main causes of renal artery stenosis, two major causes. One is atherosclerosis, which is in a sense saying cholesterol plaque. I'll just put a plaque. Okay. And the next one is fibromuscular dysplasia. So these are two most important causes. Fibromuscular dysplasia is almost always in female that are young, in their 30s. Okay. Atherosclerosis, male or female, don't matter. Mostly in men. For the purpose of USMLE, they will give you men, okay, or male in this case, and they're usually in their 70s, elderly. Because remember, atherosclerosis, plaque formation takes a long time, and abnormal diet, lack of exercise, genetics, multiple smoking and alcohol, all those risk factors, right? And If you know the risk factors of atherosclerosis, that's how you'll determine that elderly patients are, especially elderly male are most likely to have atherosclerosis as the cause of renal artery stenosis, varies young female fibromuscular dysplasia. So I wanted to highlight that. In these questions, you have young female, and the angiogram itself determines. The angiogram for renal artery stenosis that are due to atherosclerosis will show a blood vessel. So let's say this is the renal artery. Okay, it will be everything will be bright, and then it will have this narrow part like this. Okay, we just have one area that is will show stenosis. Not in this case we have stenosis and dilation. Stenosis and dilation. So beat it like a constriction and then dilation. Okay, so that's in this case. But now, so that was the first part of the question. I wanted you to be able to diagnose renal artery stenosis. Look for those things, the one I just mentioned above. Next thing is what happens in renal artery stenosis. Let me change my page. In renal artery stenosis, the things that happen is really important. Some physiology, renal physiology will be very, very important. So I'm going to try to do that. Let's do renal physiology. Okay. Let's go first. So let's say this is aorta. Aorta. Okay. Aorta will give you two renal arteries. Each of them goes to kidney. And then we have the kidney. Okay, so those are the kidneys. We want to know, so let's make one of these arteries, let's say the right side, we'll make it stenotic, the right renal artery. Maybe erase will do it. So the renal artery on this side is stenosed. Okay. Okay. So you can see right here with the arrows that the renal artery is narrow, it's stenosed. Okay. So what's the big deal? Well, so first thing we want to talk about the renal blood flow. This side, so this is the right side, let's say, for my purposes, my right hand. So the right side, the right renal artery is narrow, it's constricted, whatever the reason is. In our question, the cause of this was fibromuscular dysplasia in young female. So that means renal blood flow, what do you think, is increased or decreased to the right? Right renal blood flow, RBF, renal blood flow. So right renal blood flow is decreased, definitely. Okay, so that means less blood is going to the kidney, right? We're not concerned about the left kidney. If renal blood flow is decreased, how would that affect GFR? GFR is glomerular filtration rate. If there's less blood coming to the right kidney, less will be filtered because there's low pressure now. So GFR will decrease as well. Okay, so we're looking for these things. General physiology. GFR is the amount of blood that is filtered by the kidney per minute. Okay, if there's more blood coming to the kidney, more will be filtered. If less blood is coming to the kidney, less will be filtered, assuming all the other parameters are unchanged. Okay, the only thing that's changed is the size of the renal artery lumen. Okay, so it's constricted, it's narrow, less blood going. So there's less blood going this way. Okay, all right. If GFR is decreased, now I have to go to something else. I think you guys are aware of. Let me change my pen. Yeah, you guys are aware of. There's something called glomerulus, right? Glomerulus. So glomerulus has the afferent arteriole and the efferent arteriole. Okay, the afferent and efferent arteriole. And glomerulus simply means, let me just do this. So these efferent and afferent arteria will divide into split many branches. Okay, in between the two, you will have a tube. In this case, this tube is the, let's say, the nephron. Okay, so why am I doing that? I'm doing this so you understand the renal physiology. Let's just say this is the glomerulus. Okay, all right. Afferent arteriole brings blood to the kidney. Efferent takes blood away from the kidney. No good. Let me use my, just so you know the nephron, let's use this one. There we go. So this is the renal tubes. Okay. How would this help us? Some of you are asking me. Okay. The efferent arteriole have chemoreceptors, and I'll use these black dots. The efferent arterioles have chemoreceptor and also has baroreceptor. So baroreceptor I'll just use as beta 1 receptor. Okay, so it has a beta 1 receptor, the renal tube, the nephron. This part of this is the thick ascending. This is the thick ascending, or you can say this is the convoluted tubule. So let me put it in abbreviation. Distal convoluted tubules. So this is distal convoluted tubule, which is just about the thick ascending. So this part of the kidney, you have two types of cells. We have the granular cells, which have the beta 1 receptor, and then you have the arterial, the efferent arterial, which have the chemoreceptors. Okay, so if blood pressure, if GFR is low and blood flow through the efferent arterial is low, so now we're talking blood flow is low. If there's decrease in blood flow, guess what? Beta 1 receptor will sense that. Beta 1 receptor, when it senses that this blood pressure is low, so this causes stimulation of the granular cells, so therefore they will increase release of renin. So renin will increase. When renin increases, obviously we know the end result of renin increase is you will have increase in angiotensin 2 and you will increase in aldosterone. Okay, increase in aldosterone and increase in angiotensin 2. All of this started because of what? Decreased renal blood flow. If there's less blood flow in the kidney, on that specific kidney, in this case the right kidney, the beta 1 receptor in the right kidney will sense that there is less blood coming to the kidney, therefore there is less pressure, so it's going to get activated. So beta 1 stimulation leads to increase in renin. Renin will increase angiotensin 2 and then further it will increase aldosterone. Aldosterone increases blood volume by retention of sodium and chloride, which we said already in the previous questions, and angiotensin 2 will cause vasoconstriction. And at the end, guess what happens? Blood pressure will increase. So this is how blood pressure will always be a complication of renal artery stenosis. Blood pressure will be increased. And remember in the previous question, we discussed that. So increase in blood pressure. When blood pressure is increased, what are the complications of that? Well, increase in blood pressure can lead to headache. Okay. And further, it can lead to, in long-term, chronic complication can be Berry aneurysm or saccular aneurysm or brain aneurysm. Okay, aneurysm in your brain aneurysm. Okay, and those can be the main complication of this. Plus, because here at this part where the renal artery is stenosed, there's turbulent blood flow, and that produces a murmur. When a murmur is audible without a stethoscope, it's called a bruit. So that's where the bruit will come from. Okay, so hopefully this answered your questions. Let's go ahead and answer the question now. Yeah, we forgot. Okay, so now that we know that that renal artery stenosis, GFR to that kidney, GFR will be low, renal blood flow will be low. Renin will increase. Renin will increase on one side of the kidney, the affected kidney. Renin will increase in the affected kidney. Aldosterone will increase in the affected kidney. Angio2 will increase in the affected kidney. And sodium chloride retention. So we can say plasma sodium chloride in the affected kidney will increase. So sodium chloride retention by the affected kidney will increase. Potassium excretion by the affected kidney will increase. Okay, but plasma potassium will decrease. Okay, and it will also affect acid-base balance. So it can lead to alkalosis. Okay, so the affected kidney can produce some sort of alkalosis to some degree. So all these things. Let's see what the answers are. Okay, answers. A, decreased concentrating ability secondary to renal angioedema. Guess what? ACE inhibitors, because we're talking about ACE inhibitors, right? Like captopril, lisinopril, and so forth. Lisinopril or ACE inhibitor cause angioedema, but angioedema is not a cause of decreased concentrating ability of the kidney. That's not the thing. Okay, so that's a side effect. It's because of bradykinin, right? So that's not the right answer. Decrease renal blood flow secondary to dilation of the afferent arteriole. No. If you increase dilation of the afferent arteriole, blood flow will actually increase through the kidney. Okay. So, but anyways, we were hearing that decreased blood flow is not because of the afferent arteriole dilation, but it was more of the renal artery stenosis itself. So that's not the right answer as well. Increased concentrating ability secondary to change in permeability for collecting ducts. Not really. Remember, this is the main pathology is renal artery stenosis. It's not affecting collecting duct or its permeability to water or other things like aquaporin, which may be caused by ADH. Okay. Decreased glomerular filtration rate secondary to dilation of the efferent arteriole. Okay. Yeah, so GFR is decreased. We discussed it right here. So that's a good answer. Let's look at interstitial nephritis. No, interstitial nephritis is caused by like NSAID, cephalosporin, and other drugs, but not so much by ACE inhibitors. So our answer would be D. Okay, so question number 3. A 79-year-old man is brought to the emergency room because of severe abdominal pain, fever, chills, diarrhea. His pulse is 111 per minute, respiration 26 per minute, blood pressure is 90/60 millimeters of mercury, and temperature is 39.5 Celsius. Blood culture grows E. coli. His condition worsens, and despite of supportive therapy and antibiotic, he dies 2 days after the onset of the illness. Which of the following is the most likely cause of the initial hypotension? Okay. So we want to know what's the cause of the hypotension, initial hypotension in this patient. Okay, so to know the exact cause of this person's hypotension, we should know what is this person experiencing. It looks like this person has abdominal pain. So that's one, abdominal pain. He's experiencing fever, chills, diarrhea, and there is also diarrhea, and then he has hypotension. So hypotension and his blood pressure, and then they also blood culture, very important, grows E. coli. Okay, E. coli. Okay, in this case scenario, what conclusion would you reach when somebody has fever, hypotension, and blood culture grows E. coli? When you hear that 100% this is septic shock, or at least it's sepsis. Okay, so this is sepsis. Sepsis is infection of blood, And what determines that? In this case, blood culture is best determinant. It confirms. So let me highlight that. What does it say? Blood culture, Crohn's E. coli. This is sepsis, 100%. And then the signs also correlates. What are the signs of sepsis? Fever, okay, and hypertension. It could be hypertension sometimes, but it's okay. In this case, most of the time it's hypertension and tachycardia. Yeah, let's not forget about that. So when you have these three things, at least for me, when I hear these three things, fever, hypertension, and tachycardia. Let me put here tachycardia. Tachycardia. When I have these three things, I would always be suspicious of sepsis. Okay, so what makes me suspicious of sepsis are three things. Number one, tachycardia. Number two, hypertension. Number three, fever. Okay, so in this case, the temperature, they tell you the temperature is 39.5 Celsius, right? So tachycardia, hypertension, elevated temperature, or fever, automatically I'm thinking of sepsis. Now I'm not sure, I'm thinking, right? So to confirm that, I will do blood culture. If blood culture comes positive, then it's 100% sepsis. In this case, this is 100% sepsis because blood culture confirms that. Okay. Now the question is, what is the cause of this person's hypertension? We know that if it is sepsis or bacterial infection, the cause of hypertension or sepsis usually LPS and gram-negative, especially gram-negative bacteria. So in this case, the bacteria is E. coli. E. coli, right? Okay. E. coli is a gram-negative bacteria. All gram-negative, there's no E in gram, but you can ignore that. All gram-negative bacteria produces something called LPS. I shouldn't say all, but LPS mostly comes from gram-negative. Lipopolysaccharide. This is an endotoxin. Endotoxin. Okay, so you should memorize that. Endotoxin. This endotoxin will cause vasodilation. Okay, but how does they do that? How does it all does that? So the LPS, what LPS does, it activates nitric. Okay, nitric oxide synthase. I'm just putting NOS. Most of you are educated, you should know. Nitric oxide synthase. Nitric oxide synthase is found in the endothelium, and this enzyme converts arginine into nitric oxide. Okay, so it makes nitric oxide from arginine, nitric oxide synthase. And who activates this enzyme? LPS, in this case, the endotoxin LPS. I'll put a plus sign. So LPS activates that. And nitric oxide, if it increases, it leads to vasodilation. It's a direct vasodilator, okay? By decreasing cyclic GMP, by increasing cyclic GMP, and subsequently cyclic GMP will decrease intracellular calcium. So this is the vasodilation part of nitric oxide, okay? And who does that? LPS. Tumor necrosis factor 1, interleukins, other things can do the same thing. So let's go over our choices. Now, in this case, A, nitric oxide overproduction, yeah, that is the answer. So let's highlight that. And let's go over the other choices, why the other choices are not the correct answer. Hydrogen peroxide generation. Hydrogen peroxide generation, hydrogen H2O2. H2O2 is actually a lethal chemical for microbes. Your neutrophil usually produces hydrogen peroxide. You guys might have it, and we have it in our bathrooms, right? For infection sometime. You know, if you get a cut or something, you rub it on your skin to kill bacteria, or at least to prevent bacteria causing infection in your wounds. But anyways, hydrogen peroxide is produced by neutrophils. Neutrophils in their granules will have hydrogen peroxide, and it will kill the bacteria. I'm sure you know of a disease called NADPH oxide or chronic granulomatous disease, in which NADPH oxide is deficient. So those bacteria who are catalyst positive, they cannot be killed by hydrogen peroxide. Why? Because catalyst can neutralize hydrogen peroxide. But anyways, in this case, H2O2 is not involved in hypotension. What is the purpose of H2O2? To kill bacteria. It kills bacteria by what? After the bacteria is swallowed by neutrophils in the phagosomes or endosomes. That's how it will kill it. Hemorrhage. Intestinal hemorrhage. Does this person had any bleeding? Let's read the question again. 79-year-old brought to emergency room because they don't pay. Fever, chills, diarrhea, pulse is this, that, temperature, condition worsened despite supportive therapy, antibiotic. Nope, he doesn't have any signs of bleeding. Bleeding can cause hypotension, definitely, but not in this case. In this case, because this person had septic shock. So bleeding can cause low blood pressure. Why? Because you lose blood volume. Okay, but not in this case because this person is not bleeding. Unless he had elderly are at risk of aortic aneurysm. We did the previous question, right? Renal artery stenosis, aortic aneurysm, rupture, but there's nothing like that. Anyways, D, induction of intracellular adhesion molecule. These are called ICAM, intracellular adhesion molecule. Look at the term adhesion. Focus on A. They're called intracellular because they're produced by cells, and then they allow white blood cells to attach to endothelium. Let's say this is a blood vessel. This is a blood vessel, and here you have platelets or white blood cells. Let's say this is a white blood cells, and then ICAM comes and attaches to the endothelium. ICAM. Once ICAM is attached to the endothelium, only then can white blood cell come and attach to this. Otherwise, white blood cells cannot attach to endothelium without ICAM. So ICAM promotes adhesion of cells to endothelium. And once they're attached, then they can come and exit the blood vessels and go to the site of inflammation and help out. If a neutrophil, let's say I'll put an N in here, a neutrophil that's circulating in your vascular system, in your blood vessels, how does it know to come? And here you have a bacteria, let's say E. coli right here. You have E. coli right here, bunch of E. coli. They're rod-shaped. So let's just do, they're bacilli or rod-shaped E. coli. E. coli will produce some toxins, some chemicals, and for example, like IL-6 and stuff like that, produced by white blood cells. It recruits neutrophils. So neutrophils, to come and exit the blood vessels, they need to first attach to a blood vessel or endothelium, to the wall of blood vessel, in this case endothelium, and then only then they can exit and clear up the bacteria. Okay, so this is not, ICAM is not the cause of hypotension. It's the cause of transport or transfer of white blood cells out of blood vessels. It's called extravasation. Okay, fibrinogen consumption. Fibrinogen, you know that it's required for platelet aggregation. If this is a platelet have the receptor called 2B3A, 2B3A. So platelet, when they have this receptor, these receptors can then bind fibrinogen. So they can form this bridge between two platelets, and platelet can aggregate. So if anything, fibrinogen is responsible for platelet aggregation. Platelet aggregation. And of course, in sepsis, fibrinogen can be consumed because sometimes platelet can get damaged and they can release their activating factors, and that will lead to aggregation. So the platelets are consumed. Anyway, so after all of this, the answer should be A. Okay, let's go to the next question. Okay, so the next question is, a 72-year-old woman with a severe coronary artery disease is hospitalized to undergo left anterior descending coronary artery bypass grafting with a portion of the great saphenous vein. To remove a portion of the vein, an incision should be made in which of the following location? Okay, so the question is asking, a female 70-year-old woman has she has severe coronary artery disease, therefore she needs a bypass. To do the bypass, you need a vein. So which, in this case, saphenous vein. Where would you make the incision? To take a portion of the saphenous vein and make a graft out of it. Okay. All right. So that's the main thing. Remove a portion of the vein. An incision should be made. Incision should be made in which of the following locations? So where would you make the incision? This is more of anatomy questions. Okay. So and it's telling you already Which vein are you going to use? You will use the great saphenous vein. And I highlighted it for you. You will use the great saphenous vein. To remove that portion of the great saphenous vein, where would you make the incision? To answer the question, you should know anatomy of the saphenous vein. If you don't, then it's not helpful. Okay, so let's see if I can do something. Let's draw a person. So hips, legs. Sorry. So just think of it. It has a little bit gut. I'm sorry, but whatever. Okay. So this person, let's say here the medial. So this is the lateral side, and this will be the medial side. And let's say here we have the malleolus. That's important. Here we have the knee, and here is the hip. So this would be the groin area and hip bone. So just to have some landmarks for us to know. The great saphenous vein starts on the medial aspect of the foot, let's say in this case, and it goes anterior to medial malleolus, which is on the inside of your foot or ankle, not on the outside, and it keeps traveling on the medial side of the knee, and it travels on the medial side of the hip, okay, and then it will join a femoral vein, which is much bigger vein. Okay, it will join the femoral vein. So this will be the femoral vein. Femoral vein. Okay. So this is the saphenous vein, the great saphenous vein, okay? The great saphenous vein is a superficial vein. Femoral vein is a deep vein. Now, the deep veins of the lower extremities are more important in draining blood from your legs compared to the superficial veins. Superficial veins are not that important. So even if you take a small area of it, it wouldn't affect blood flow that much. But we prefer to cut right here, right? So that means this area will be affected. But if we cut it right here, it's not a good idea. That means then the whole lower extremity cannot be drained. So the deep veins are more important for drainage of your lower extremities, not superficial veins. Therefore, the cut should be made. Where is my, okay, go to my pen. There you go. The cut will be made, so this much section will be taken out. Okay, if you don't like the red, I'll use green. There you go. This much section, let's say, is needed, and that will be cut and used as a graft for corneal bypassing. Now the question is, they're asking for anatomy, right? So at which location? So you should make incision in that green area that I said. Let's see which of the choices corresponds to that. Along the lateral surface of the leg. No, I already told you the vein courses or travels on the medial aspect of your leg and thigh, okay? And eventually it joins the femoral vein in the groin area. So this is on the inside of your legs, not on the outside. And this will be the medial malleolus, right? And then B is along the medial side of the ankle joint. Yes, that's a good choice. Okay, so we said A is incorrect. Along the plantar surface of the foot. Plantar surface of the foot will be right here. Okay, so it doesn't travel there. That's incorrect. Anterior to the knee joint. It doesn't travel anterior to the knee joint. It travels medial to the knee joint. Medial. Okay, not anterior. Posterior to the hip joint. No, it doesn't travel to posterior to the hip joint. It travels medial to the hip joint. Okay. At the femoral triangle in the groin, yes, it joins femoral vein in the femoral triangle. So, but that's not where you will make the incision. So it is true. F is correct. It's a correct answer in the sense that it joins, it's located in the femoral triangle. That's where it joins. This is the femoral triangle, right? So it joins femoral vein, but you're not, as I discussed before, you don't want to make incision in that area, okay? You want to make incision in the beginning of the vein. All right, and also when you take the vein, you want to turn it around so the valves will not be obstructing blood flow to the heart. So let's hope you understand. This question was helpful. So the right answer will be B, along the medial aspect of your ankle joint. This is strictly anatomy questions. So let's go next question. Okay, so the next question is, a 66-year-old woman is brought to the emergency department 30 minutes after the sudden onset of pain and coolness of her left leg. Her medical history is significant for diabetes, hypertension, and hyperthyroidism treated with metformin, lisinopril, and PTU, propylthiouracil, respectively. Examination of the lower extremities shows normal skin, nails, and hair growth patterns. Pulses are absent in the left lower extremity and normal on the right. Which of the following is the most likely cause of this patient's symptoms? Okay. So it looks like this person has limb ischemia. Okay, limb ischemia. How do you know that? Well, look what it's telling you. Which of the following is most likely cause of this patient's symptoms? The patient's symptoms are pain in the left leg and coolness, and there's no pulses. So that means the blood flow to that limb is decreased. Okay. Limb ischemia. So number one, let's say what are some symptoms of limb ischemia? How do we identify it? So pain. And the pain is usually not bearable in acute limb ischemia. Pain. Okay, so there's pain and there is coolness. In this case, you can say coolness. This question is giving us that. Or you can say low temperature. Okay, plus there is no pulses. Okay, so decreased pulses or pulselessness. That's the three. So whenever I hear that, I'm going to think of limb ischemia. Now, the issue here is there are two types of limb ischemia, acute and chronic. So which one is it in this case? Acute and chronic. Okay. Let's talk about the causes which will help us. Acute is usually due to embolus. Okay. Embolus or emboli. Emboli is many, embolus single, right? And chronic is usually due to plaque, atherosclerotic plaque or cholesterol plaque. The risk factor responsible for emboli are number one, AFib. AFib is number one, atrial fibrillation. Number two, let's say, then endocarditis. You can think of endocarditis, maybe cardiac tumors. And then you can also think of CTA or angiography, right? Vascular procedure. If the person has atherosclerosis of large arteries like aorta or aneurysm, okay, aortic aneurysm, if you do angiography, this can disrupt the aneurystic plaque that's there, the cholesterol plaque, and it can make small cholesterol plaques and can cause some problems. So angiography, I'll just put angiography, but you're smart, you should know that vascular procedure in patients who have risk of atherosclerosis. Okay, risk factor for plaques are diabetes, elders, smoke, cholesterol, right? Alcohol, and hypertension. Okay, so those are some things that would help us. Now let's see in this question to see what this person is having. Okay, so this person's an elderly woman who's brought to the emergency room 30 minutes after sudden onset of pain. Sudden onset of pain. So the pain in acute ischemia is sudden onset, and the pain in chronic ischemia would be more like angina. It comes and it goes. Okay, it's intermittent. It's intermittent, such as claudication, like a person walks a long distance and start having pain. Why? Because as you walk, the demand for blood to your muscle increases, but your arteries are narrowed to your legs, and the leg muscles are not getting enough oxygen and nutrient, so they will start going under cramps or pain or so forth. Okay, so the pain in acute ischemia, limb ischemia, is sudden onset. The pain in chronic limb ischemia is intermittent. and usually exertional, exercise induced, activity induced. Okay, so the coolness is with both of them. Medical history significant for diabetes, hypertension, hyperthyroidism. Okay, so that gives you like a risk factor for a plaque. Um, and he's on medication. Examination of the lower extremity shows normal skin. Okay, that's important. When you suddenly have no blood flow to your legs, there's not enough time for your leg hair follicular cells to die. In chronic ischemia, the hair follicles die, and usually the skin will be uh, there will be no hair. It will be like smooth, hairless, and the skin will be like shiny and cool and so forth. So because this one person shows you hair growth is pattern is normal, nails are normal, skin is normal, so this is unlikely to be chronic. So this is most likely acute. So this is acute ischemia. Pulses are absent. Pulses in acute are absent, and in chronic could be decreased. It's not absent in chronic. So pulses are absent. That's another thing for acute. What else? Okay. So there you go. We know now from this, we know that this person is having acute ischemia of his left leg or her left leg. Okay, what could be the cause? We are seeing nothing. I should have given you something. Okay, let me see. Oh, there you go. So there's a clue actually. What could be the cause? Let me highlight that. This person has hyperthyroidism. Not a good highlighter. Let's change. Let's use this one. Hyperthyroidism. You know, hyperthyroidism is associated with AFib. Hyperthyroidism is one of the common causes of AFib. Okay, so AFib. Atrial fibrillation. So this person is most likely having acute ischemia because of the emboli produced because of AFib. AFib or atrial fibrillation, the left atrium doesn't contract properly. It just shivers, and blood is not being pushed properly, so it actually leads to blood stasis in the left atrium, and this puts you at risk of cardiac emboli or cardiac thrombus formation. And these thrombuses are called produced by the wall of the heart. Okay, all right, so let's go through these choices. Now we know that this person has hyperthyroidism, and most likely this person acute limb ischemia is due to emboli produced by AFib in the left atrium. Endocarditis definitely can produce emboli, but those will be infectious emboli, small valvular. They come from valves, cardiac valves. I should say cardiac valves. Cardiac valves. Cardiac valve emboli. Okay, cardiac valve emboli. Okay. We don't have any clue, anything that tells us this person has endocarditis. If he have endocarditis, what are we looking for? The triad, the three things that I always love to memorize and understand. The three things for endocarditis. Number one, look for fever. Number two, look for rash. And three, look for new onset murmur. This person doesn't have any of them. So therefore, I'm not going to go with endocarditis. Okay? So this person doesn't have endocarditis. Deep venous thrombus, DVT. Okay, DVT, remember these are veins. These are thrombus that are produced by, I will just put DVT. Deep venous thrombus are produced by what? By veins, right? And if they're produced by veins, they're not going to obstruct blood flow. They're not going to cause arterial blockage, and there will be no loss of pulses in that case. Because for a deep venous thrombus to travel all the way to the left side of the heart, it has to bypass the lungs. And there's no way, unless the person has ASD and VSD. So the only way DVT will travel to the left side of the heart and cause arterial thrombi. So this person has arterial, not venous thrombi, right? Arterial embolus.